This ECG looks like atrial fibrillation, but it is definitely not. If you look at the arrows that are marking the P waves, you'll notice that the P waves are a bit odd and they are non-identical. What do you think it is then? Hello everyone, welcome to the Rhythm Files episode 6. Let's see if you got the diagnosis right. Okay, so this non-paroxysmal irregular atrial tachycardia is known as multifocal atrial tachycardia. Now, if you notice the ECG, you'll see that the first P wave that I marked with red circle appears inverted, the second one appears normal, and the third one appears tall and tented. Now, this occurs because the multiple atrial foci are present which produce different kinds of P waves and give us different morphologies. So some key ECG features include irregularly irregular rhythm, multiple P wave morphologies which have to be at least 3 different P wave shapes. Then there is variable PR interval, narrow QRS complexes, variable atrial rate which is usually more than 100 beats per minute, and ventricular rate which is also usually more but it varies with atrioventricular conduction. Now, the patients of MAT usually present with underlying lung disease or an electrolyte abnormality. So, let's see why atria are affected more in this case. So, the first thing is there is higher automaticity due to multiple latent pacemakers in the atria, and they are more prone to changes due to hypoxia. There is right atrial stretch, especially in COPD patients, which is a key driver in development of MAT. The drug effects of COPD therapy, especially with respect to beta agonists and theophylline, can alter the automaticity and the camp in the atrial cells. There is electrical instability, and also that the ventricles are relatively protected in this case due to lack of multiple latent pacemakers. So, the treatment of multifocal atrial tachycardia usually involves treating the underlying cause, correction of electrolytes, rate control, especially with verapamil or diltiazem. They slow down the AV node and they are effective in arrhythmias of atrial origin. We have to use them cautiously in hypotension and LV dysfunction. Remember that cardioversion does not work, adenosine has no role here, and routine antiarrhythmics are usually not necessary. In severe cases, slow dose beta blockers can be given cautiously and ICU monitoring may be required. Thank you. Please like and follow.